at the Barrow Neurological Institute in Phoenix, Arizona, and I'm the Chief Medical Officer of Gravity Medical Technology. And I'm really excited today to have this special conversation on a groundbreaking medical advancement. Today, I have the privilege of speaking with Professor Fazal Zaidi. I call him Syed. He's an interventionalist and a stroke neurologist who's really, along with his partner, pioneered a brand new program in Toledo, Ohio, and they've grown to rapidly become leaders in the space, both in the research, education of residents and fellows, as well as excellent clinical care, really providing care to an area that did not have interventionalists when they first joined the practice. And he's going to be talking about the first successful use of the Supernova device in Pakistan. So, Professor Zaidi, before we dive into the first case, could you share a bit about your background and what drew you into this field, kind of going back to early days, and just give us a sense of your journey?
Thank you so much, Ashu, and thanks to the entire Gravity team for this opportunity and wonderful work you guys are all doing. Knowing you all, I'm exceptionally proud of all the work you have done so far and laid the foundation of this breakthrough technology. My background, again, is stroke and interventional neurology. I trained at the University of Pittsburgh, both for my stroke fellowship as well as interventional fellowship. I finished training in 2012. I've seen the field from the beginning almost. When we started with the earlier trials, we were at one point one of the highest enrolling center for the IMS3. That was way back when in 2009 to 2012. And seeing the field like transform the care we provide to stroke patients, it's just been so remarkable, right? It's like everyone's experience here. Since my training, I've been at the University of Toledo. And as you mentioned, we laid the foundation of the very first program in Northwest Ohio. We have a catchment area for about 1.5 million population. A lot of strokes, unfortunately, and we are a comprehensive stroke center since 2015, part of multiple trials, both investigator initiated as well as industry sponsored, and as well as a fellowship training program.
Yeah, it's an amazing journey. And like you said, the field went from thrombectomy doesn't work to now we're doing large core patients, and when doesn't it work? And maybe MEVO and distal MEVO is going to be our sort of next challenge. So what I wanted to do is kind of go back a year, since this is kind of the anniversary of that first case, and if you could walk us through the patient's condition, a little bit about how triage and how patients present in Pakistan, and then the specific of this case, how this case specifically was challenging. What were the sort of clinical considerations?
Absolutely. How would I go back a little further? In the sense, just talk about my journey going to Pakistan and as to what I was doing in Pakistan to begin with, right? So I grew up in Pakistan. I graduated from medical school in Pakistan in 2001 and subsequently came to the United States for my residencies and fellowships. So all along this, as we were advancing our stroke science as well as our careers in stroke and neurointervention, one of the questions that always bothered me was, you see these successes of these patients presenting with devastating stroke symptoms, and you do a thrombectomy, they recover, they go back home. But what happens to these patients, say in India or say in Pakistan? I mean, the disease is the same everywhere, right? And come 2022 to 2022, I had this opportunity to go to Pakistan and see for myself in one of the public sector hospitals, a large public sector hospital in Karachi, as to how they were tackling stroke. And it turned out that very few, and Karachi is one of the largest cities in the world, the 7th or 8th largest city in the world, 25 million population. And for a city so large, so humongous, there was at that time not a single center providing 24/7 thrombectomy to the patients. Some private centers may do it, but just because how expensive the treatment is, or was at least at the time, very few patients were getting the required treatment. At that time, in 2022, we did the first workshop, and to us, and I think it's a little bit frowned upon in the stroke community, but what we did was we started engaging our colleagues in interventional cardiology because they already have catheter techniques, they already have access to cath labs. And we did the workshops and seminars and live cases, and trained a group of cardiologists at one of the leading interventional cardiology center in Karachi to start providing thrombectomy care. Thankfully, we had some help from the administration and some political help as well. They were able to get the required equipment and devices, whatnot, to be able to conduct these procedures. I'm proud to say that that group of cardiologists has since expanded. They are doing these thrombectomies not just at the main hub hospital in Karachi, but they have expanded outside the city of Karachi as well, in some other smaller cities as well. Having said that, though, there's a lot that needs to be worked on still. As far as, for instance, say, hemorrhagic disease goes, there is barely any access right now, even in large cities of Karachi, or even large cities of Pakistan, let alone rest of the country. So with that journey in mind, I have myself and group of my interventional friends hailing from Pakistan. We have made multiple trips to Pakistan in different cities, doing these live cases, webinars, hands-on cases for our colleagues in Pakistan, both interventional cardiology, but other interventional radiologists as well. And hope is to, in the coming year or so, is to come up with very first comprehensive stroke center there. So with that background, going back to the first Supernova case, one of the barriers for patients being able to get thrombectomy there is the cost. Treatment at private centers is very, very expensive. Most working class population is not able to afford it. So our experience, when this opportunity came to that this device is being offered and it's being investigated for patients in that part of the world, in that region of the world, to be able to provide access for all, essentially, for stroke care. This was an opportunity that we jumped on. As you well know, we were the first centers at NICVD Karachi to get the IRB approval and to get the study initiated. We were able to enroll the very first patient into the trial, and I'm proud to say that the procedure was very successful. There were some challenges, obviously. I remember distinctly, this was a 65-year-old lady. She presented with acute onset left hemispheric stroke symptoms, and NIH stroke scale score was high. She had tandem disease, not that the proximal lesion was in the petrous ICA, very, very tight there. And simultaneously, she had an M1 occlusion. And we uses the Supernova device to access the MCA thrombus and were able to successfully recanalize. One of my concerns was because of the proximal ICA lesion in the cervix, in the petrous ICA, I was not able to use my traditional techniques. So personally, I like to use a Salumbra technique, deploy the stent retriever, and then simultaneously advance the aspiration catheter into the stent retriever and basically engulf the clot, ingest it, and pull them simultaneously. Because of the petrous ICA lesion, we were unable to advance the catheter into the brain. So we had to rely solely on the Supernova device to do the trick for us, which again, I mean, an experience hasn't, it's shown to work. But it was very, very nice and very encouraging to see that after the first pass, we had excellent recanalization in this case. That was the very first use, as you well know, of this device. I know I went on a tangent right now, but I hope that answers the question.
No, absolutely. And I think that what you've done there is remarkable to try to improve access in Pakistan. And I think sometimes we have to be mindful of the local resources. And in some environments, it is politically charged in terms of who does procedures. But in other environments, you have to be pragmatic and say, okay, we need to get going and we need to have whatever specialty background do the cases and share perhaps biplane machines and have a much more broad approach to treatment and training. You mentioned a little bit about some of the barriers in Pakistan in terms of getting access to care. I wanted to talk a little bit about the biology of stroke in Pakistan. We know it's the major cause of morbidity, mortality, and you've practiced in the US. You go back and do cases routinely in Pakistan. So you've kind of got a unique perspective here on some of the differences encountered in different background patients. And, most of the trial data we have is in a specific population, predominantly North America, Europe. We're getting more data from China, but really big gaps in data in other populations from Africa and most of Asia. So just some thoughts and sort of encounters that you've had in terms of differences in that biology and population dynamics.
Absolutely. This is a very important question because until we know the biology, the stats, the disease that we are dealing with, it's very hard to come up with solutions. And one of the barriers, Ashu, that I have noticed, at least in Pakistan and even in major cities there, is lack of data that we are so used to. Like in the US, for instance, we have the Medicare registries and data coming from insurance companies and local AHA resources and multiple of registries through which we can cull the data and know exactly what's happening with the population, or at least get a fair idea. In most major cities in Pakistan, we have very little idea about the burden of the disease. We know it's high. Look, so for Karachi, at least we know that any given year, there are over 20,000 strokes in Karachi alone. In Pakistan, we suspect this again on the numbers is that the number is over 350,000 stroke patients. The percentage of patients who receive the thrombolytic treatment, the fraction of the patients who receive the interventional treatment is unfortunately dismal in this right now. Biology clearly is different. In my experience, stroke is happening to much younger subjects there. Rheumatic heart disease is still very common there. I see rheumatic heart diseases related valvular abnormalities and valvular atrial fibrillation leading to embolic strokes in much younger subjects there. Not uncommon to see kids really in their 20s and 30s to us, so 20 and 30 coming to us with large hemispheric strokes, with LVOs. So it is different. ICAD is another entity that is again rampant. I think both from a public healthcare messaging, dearth of risk factor controls, and I think also environmental factors as well. Because AQI in most of those cities, both in India and Pakistan, any given time is atrociously high. The impact of it on the intracranial disease, I'm sure it's significant. I don't think we have numbers to prove it though. Yeah.
Now you focused on the sort of specific hospital and center, and you mentioned how the interventional cardiologists have now gone on to train other folks. So how has the penetration of this stroke thrombectomy and stroke care impacted neighboring hospitals and neighboring regions? What is the success in trying to get that to happen, and what are the barriers?
Yeah, so numbers keep going up in terms of the thrombectomies being done, say in Karachi, another smaller city, Tando Muhammad Adam, another city in interior Sindh, province Sindh, Sakhar. So the numbers keep going up every year, and that's very encouraging to see. On our end, through our organization, because we have a nonprofit Pakistan Stroke Initiative, we were able to procure rapid AI for these centers as well, which certainly has helped the local physicians to be able to find more patients who are eligible candidates for thrombectomy. So that has been successful. There are numerous issues, though, from a triage perspective and public service messaging as well. There is a significant knowledge gap in population at large with regards to stroke. A lot of times strokes are happening and patients are going to smaller hospitals, which are ill-equipped to take care of those patients. And there are no triage pathways established where a smaller center would automatically transfer to the mothership. That does not necessarily happen. So it requires a lot of work right now in terms of making networks and system of care. That would be our next goal, is to be able to connect with all the local regional hospitals, because every certain district has a regional hub, and making this process of transfer from a smaller hospital from the say spoke to hub, that would be the next goal for our organization.
Yeah, I think that some of the challenges you describe are sort of shared in other regions that are trying to basically bring this technology online. We have folks on this webinar from all around the world, and are there particular piece of advice you could offer because you've kind of taken, this journey kind of all the way through. You started in Pakistan, came to the US, you've developed the skills, now you're taking devices and techniques back to Pakistan, and there's a crosstalk, which I think is very valuable because it allows you to stay sort of aware of the relevant challenges. So is there a way to zoom out here with lessons learned from Pakistan that you would offer as advice for folks in other regions in terms of surmounting some of these similar challenges?
Yeah, so one of the things that I learned in this journey was the importance of making connections and networking. There are the local physicians here are the heroes in my mind, the ones who are there at the front line and providing care to these patients in those challenging scenarios. Quite a few times, it's not uncommon in the middle of a procedure to just learn all of a sudden, okay, we don't have X, Y, Z, and now you have to think on your feet and come up with an alternate solution to do the very best for your patient. So in a resource-starved setting, to be providing this high-end treatment, kudos to our frontline physicians in that part of the world to be doing the amazing job that they're doing every day, day in and out. With that said, though, being open to form relationships and networking, I think that has been the key. Respecting the local, like, because you can come across as someone, okay, so you coming from United States, he thinks he is a knight on a white horse coming to save us, humanity. That's not how it really works. You have to be able to work within the system. So being open-minded, being able to network, being able to respect the local dynamics, I think that's very, very important to be successful in this journey.
And and I don't know the specifics, but can you talk a little bit about engagement with the government, local government, Pakistani government? Is there some ways that have been successful in which the government has engaged in this process? Obviously reimbursement's a big challenge. So can you talk about that a little bit?
So I'll backtrack just a little bit. So certainly we were able to connect with the government at the health ministry level and show to them the importance of being able to provide care for patients with LVO and be able to perform thrombectomy and reverse one of the worst form of strokes. But then even within the physician community right now, I think one of the major gaps is hemorrhagic disease. So subarachnoid hemorrhage in Pakistan, in most of Pakistan, is a death sentence to most people, unfortunately. Very few centers are able to provide the required care for these patients. The endovascular treatments tend to be very expensive. Our flow diverters and intrasaccular devices which are coming online are very, very expensive. Most patients are not able to afford them at the private centers. And population at large, working class people, they rely on public sector hospitals which do not have these tools and technologies. A lot of patients still rely on getting craniotomy done and open surgical clipping, which again, for deeper lesions, ACOM aneurysms, posterior circulation aneurysms, as you very well know, it can be very detrimental even to a certain degree. The system is just used to, okay, I shouldn't being a little blunt there almost, but the system is almost just used to the fact that these patients perhaps would not do well, so why even invest in the resources? Like, it's a lack of knowledge right now. What we are trying to do is change that through our organization. So we have been constantly in communication with the government. Hope is to be able to come up with multiple comprehensive stroke centers and also be able to invest in technologies that these patients need to be able to treat them and at least provide them the basic care. Go ahead and at least be able to provide basic coiling for most of these aneurysms. So that's what we are working towards right now. See, the government knows what government knows. Until there is education coming from the healthcare system, unless someone is raising a hue and cry, they would not magically just go ahead and put money into a problem that no one is even complaining about. So that because of the lack of knowledge, because of I think lack of ask from the government even to a certain degree, there has not been much of an impetus to develop comprehensive stroke systems. But I think that's changing now. I think over the next 4 or 5 years, I think the landscape would change remarkably.
Yeah, I mean, absolutely. I think there is a sense of nihilism about some of these patients where historically the outcomes have been categorically very poor. And now that there's
Mhm.
treatments that can reduce disability and mortality, the next gap is awareness and engaging with the stakeholders to try to support growth of that access to that treatment and growth of that sector of society. Now, I know that you and your colleagues in Pakistan have been really looking at this from a big picture standpoint with the Pakistani Stroke Initiative, and I really wanted to hear more about how this started and what the sort of goals are and where you sort of hope to take this.
Yeah, so as I alluded to earlier in the conversation, I started making frequent trips to Pakistan in 2022, and along with my colleagues, uh, you know, we first started trying to understand the magnitude of this problem, which is humongous. And we would make these trips every couple of months and perform or try to help patients with complex brain aneurysms or help with starting the clinical trial, for instance, for the Supernova, and which have been very successful, except that given the burden of the disease, it's not making much of a dent into the problem that we are tackling right now, right? And that's where the Pakistan Stroke Initiative comes in. Again, between myself, a bunch of my colleagues, physicians in Pakistan, uh, some politicians as well, with some political backing. The goal is again to one, provide more awareness regarding stroke, presentation of stroke. So with regards to that, like how we use BFAST acronym, we actually came up with an acronym in say Urdu and Hindi for that purpose, which is for the audience who would understand, जब बंद हो जाए हाथ, चेहरा या जबान, फौरन करो इलाज, बचाओ अपनी जान, which basically translates roughly into, if your tongue stops working, you can't talk, you can't move your arm or leg, you know, get treatment quickly, save your life. So it's a catchy phrase. We're hoping it will catch on. So it's a like public awareness or public messaging campaign. A lot of physicians themselves don't have much of a knowledge regarding stroke and stroke care. I tend to say that stroke in that part of the world is sort of an orphan disease. Most of the neurologists, they are in general neurology practice. Stroke is managed mostly in the medical wards where the internal medicine physicians are not necessarily trained in neurology themselves. So they're not very uh, excited about managing these patients. Again, there are exceptions everywhere. But in general, um, and as you so eloquently put it, there is sort of a nihilism regarding these patients, with regards to their outcomes and whatnot. So changing that landscape, it requires so much education that needs to be provided both at the public level as well as the healthcare level. And that's what we will be focused more on in the coming few years.
Yeah, it's really inspiring. And I think that, from a gravity mission standpoint, this is exactly the poster child for what we hope to see happen, which is trying to understand the grassroots issues in each environment, engaging with all the key stakeholders to make things happen. Because this is a lift, you have to get advanced machinery, you have to get advanced procedurals to do the procedure. And then there's just the reality of cost of devices. And
Mm-hmm.
one thing that we also tried to do when we developed the Supernova device was to be attuned to some of the um, challenges specifically in other populations where there's more ICAD, where there's more white clot, fibrin-rich clot, and that's really been a big part of our research focus. And through Gravity Mission, we're also trying to collect clots from different populations of patients. One of the feedbacks we're getting from some countries is that even the size of the vessels are smaller than in the sort of traditional North American European population, and that also impacts potentially design development of these devices. So as you kind of have gone back between the U.S. and Pakistan, first I want to just thank you for sharing your journey with us, but just any additional closing thoughts in terms of where you kind of see this going in the next 5 to 10 years, especially because now we're at this point where you reflect back on the last 10 years, which have been very exciting, but there's obviously a new set of challenges.
Yeah, so one way, and then this, you're absolutely right, right? Like this is now where we need companies like Gravity coming into play, trying to, I love your mission statement, which is trying to democratize the stroke care access to everyone, which is incredible and which is very noble and very needed. One way I think about the current state of affairs with regards to stroke care is how it used to be for interventional cardiology in late 90s and early 2000s. Like if you go across Pakistan, cardiac care is actually fairly available. Most patients understand the signs and symptoms of acute chest pain and what needs to be done. There are numerous centers around most cities which are able to perform acute coronary interventions and have protocols in place and very reasonable outcomes. Would that be true also for LVO in next 10, 15 years? It's very plausible. I think for that to happen, though, we need to start making changes today, which includes, again, development of multiple of these primary and comprehensive stroke care systems, along with triage pathways and just general awareness that yes, you're having a stroke, but there is hope available. You're not destined to just die but just be devastated from it. And I think that messaging remains very, very important.
Yeah, no, I completely agree. So I've asked you a bunch of questions and really appreciate your sharing your experience and your thoughts. But we do have other people that have joined the conversation, and I just wanted to open it up to see if there's anyone on the call here. We've got folks from all over the world dial in. And so I'm going to see if there's anyone here that'd like to kind of make a comment or ask a question. You should be able to raise your hand, or I don't know if there's a way we can give people access here. But really what you're describing is a challenge in many parts of the world. And I do think it takes people like you and this commitment to wanting to look beyond your backyard, because it can be very easy to be comfortable in your own practice and then putting yourself in a different environment. So I think we're able to mute the other microphones. And so I don't know if anyone wants to raise a hand or ask a question here. So I see we got folks here from, we got Erdem here from Turkey. Erdem, how are you?
Oh, hello. Can you hear me? Thank you. Very nice to see you, and I really appreciate your efforts, your valuable efforts for these unorganized countries. Thank you so much, and good things from Turkey. I would like to ask you how you organize the emergency services in Pakistan.
And that's an excellent question, Ardham. Thank you so much for that. So again, yeah, as you allude to, having a functioning emergency system which can bring the patients to the right center, it's key to be successful in this line of work. In Karachi, for instance, it's a massive city. There are several major ambulance service providers. Few of them are organized by the government based on the locality or the geography. Two large networks, they actually come from charitable organizations. We are talking about thousands and thousands of EMS providers. So with regards to that, we have done a public service campaign, held some webinars, and also have created a YouTube library of sorts about stroke recognition, signs and symptoms, which has been translated in Urdu. So the idea is to explain again to our EMS providers, the crew, as to what stroke signs and symptoms are, how to kind of distinguish between, say, a minor and more moderate and severe strokes. And if someone is experiencing moderate to severe stroke symptoms, to perhaps take them to a stroke or thrombectomy ready capable hospital. We have identified a list of those hospitals which we have previously publicly shared, the hospitals that we know of that are able to provide, again, thrombolytics or at least are thrombectomy capable. So there are a few of those centers, both in public and private sector hospitals. And it's very important that the EMS crew knows what those centers are so that they can take them there. One of the issues remain, though, because of lack of knowledge within the population at large. A lot of people try to transport these patients themselves in the back of their vehicle, and they would try to go to the nearest possible hospitals, which may not even have a CT scan in some cases, right? So that remains a challenge that needs to be worked on. Thank you for that question, though.
That's a great question, and there's different challenges in different regions. So we have Miguel Letao also. He's a Filipino ancestry, but he's in New York City. But Miguel, I wanted to hear your perspective on Southeast Asia.
Oh yeah, so the Southeast Asia is very heterogeneous as well. There, as you know, there's countries like Singapore, which are very wealthy, and there are countries like the Philippines, which I can speak of, which is kind of in the middle. My practical question for you, and thanks for the talk, by the way. Do you split your time between the States and in Pakistan? Because it's what obviously is one way to kind of help everyone, help the folks back home get things going, with your presence. But like, is it something you practically, would do in the next couple of years?
Yeah, I was hoping no one would ask me this question. So
it's
Miguel,
kind of tricky nowadays as well, politics aside.
Absolutely, you're right. No, so the reason I make a jest about it is because I don't take a specific time off from work per se. So in my line of work, I don't know how it's organized for you for your college schedule, but I am on, say, 2 weeks in a row, but then I have an administrative week of sorts, where basically I'm supposed to take, catch on research and do all the administrative work that's piling up. I take that administrative week essentially, and that's, so I would fly to Karachi on a Saturday, get there Monday morning, and through Monday, Tuesday, Wednesday, Thursday, we would have cases lined up. Most of the time, they need help with floor diversion cases or stent-assisted coil embolizations, intrasaccular devices. We have also been part of the Galaxy Seal trial there. Like, actually, we made Pakistan one of the first in human sites. Yeah, we made Pakistan one of the first in human sites for the Galaxy intrasaccular device, along with the gravity at the same time, right? So, being able to take research home, that has been very exciting. So my point being, when I go to Karachi, I'm there for 3-4 days. I basically churn out 10 to 15 cases during that time. I have been meeting the schedule already beforehand with the hospital leadership, city administrators, as well as the healthcare ministry. So we go through what we have to talk about, obviously. And then near the end of the week, I fly back home. So it's taxing on the body, but it's certainly doable. Over the past 3 years, I must have done 15 such trips to Pakistan and back. So yeah, that's how I have been doing it. That's how I've been splitting my time.
Is there a society of sorts already? Like I don't know, a Pakistani, Indian, or Sri Lankan society of neuroendovascular physicians, among different specialties?
Yeah, so within each host country there are societies. So there is a Pakistan Stroke Association, I'm sure, and then I don't know of it, but I'm pretty confident that India would have something very similar. But I don't think we can certainly have a society of sorts which covers that region. Like a SARC, which is a political committee of sorts. We can have a society which can put these countries together. So Pakistan, India, Sri Lanka, Bangladesh, Myanmar, and then Southeastern countries as well.
Yeah, Myanmar is actually part of the ASEAN, technically. The ASEAN nations.
Historically, we take it part of India, so that's why I added it
there. But anyway, yeah. So that's an interesting thing, because I know there are those from the radiology tradition have an ASEAN society of sorts already. It's kind of interesting to tap, Anyway, just that's an aside.
Absolutely.
Well, Syed, I really
Actually,
wanted
one more thing. One more thing I would like to just quickly add there, though, and I think that's probably applicable to others in the group as well. Whenever I go to Pakistan and I'm doing these complex cases, right, and these are the cases that the local physicians, they have not tackled before themselves, and just because of, and not that they are lacking in skills by any means, they're exceptionally well skilled. It's just that there are only so many floor diversion cases they've done, right? So they don't have the experience and expertise in doing them. So that's why they need me. In fact, to be honest, they need my bag more than they need me. If I just go and drop my bag, the supplies, and they'll be like, okay, I'll see you later. But one thing that I always think of, and I think we miss, is the possibility of taking trainees to that part of the world. See, the week I am there, the 3-4 days I'm there, it's an invaluable learning experience for any neuroendovascular fellow, or for instance, even a junior attending. There are quite a few fellows being trained right now in the United States, or early career physicians who would love to have that kind of experience, be able to churn out 8-10 floor diverters over a course of 2-3 days and fly back home. And I'm sure there are similar opportunities can be provided to them for them. So I think we need to organize our efforts with regards to that, because it can be a mutually beneficial experience for everyone.
Yeah, no, that's a great point. And I just listening to your schedule and what you do, I think this is a lot of work, a lot of commitment, a lot of dedication, and I wanted to congratulate you for what you've done. It takes a lot of trust building to go into another country, another system. I know you're from Pakistan originally, but you have to establish trust that they have you do cases there, and it's a tremendous public service. So I want to thank you for your time this evening. Thank everyone here for joining us for this conversation. Really, for us, it's exciting. It's the 1-year anniversary of the first case in human, and really grateful to you, Syed, particularly for really pioneering that first in human effort. So I'm going to end the webinar here, and thank you for your time.
I should thank you so much again.
Thank you.
Thanks everyone who joined.
Thank you.
Thank you so much.
Thank you, everybody.